A very good evening and welcome to one and all who have joined us for today's session. Today we have two of our most distinguished faculties, Dr. M. Karthikeyan sir and Dr. Prithviraj sir, Junior Resident, Department of Pediatrics, Bardhaman Medical College, West Bengal. Today we have a pediatrics case presentation of nephrotic syndrome, and for presenting the case, I kindly call upon Madhumita R, studying in final year, Tagore Medical College. Madhumita, you can start.
Yes. Good evening, sir. This is Madhumita here to present a case on.
Welcome.
Okay. I'm here to present a case. 2-year-old male boy named Ramu, who is residing in Kelampakam, whose informant is mother, which is reliable. Date of admission is 20th May, and date of examination is 22nd May. The chief complaint is puffiness around the eyes for 3 weeks, swelling of upper and lower limb for 2 weeks, abdominal distension for 1 week, reduced urine output for 1 week. History of presenting illness. Child was apparently normal 3 weeks back, after which he was brought with complaints of puffiness around his eyes, which is insidious in onset, gradually progressive, initially involving the periorbital region, more in the morning, and reduced as the day progressed. After 5 to 6 days, the mother has noticed swelling of both lower limbs, which is insidious in onset and progressive from feet to knee, and then swelling in both upper limbs from hand to elbow, more during in the morning hours, and then reduced during the day progresses.
Can you stop here? So what is your first impression at this level?
It is renal pathology.
So how you are telling it's renal pathology? Either it can be cardiac or some other reason also, no?
Yes, sir. Because in renal pathology, the puffiness will be seen in eyes first. If there is any cardiac pathology, then the pedal edema will be seen. If any hepatic or liver pathology, then abdominal distension will be first seen.
Okay. So any other differentials for generalized edema or anasarca?
Sir is asking, apart from hepatic, cardiac, and renal cause, what are the other differential you would like to tell for Anasaka? Are you getting the question?
Yes, sir.
Yeah.
Which is the most common?
Angioedema and hypothyroidism, kind of mixed edema.
And also another thing, which is very most common in our society, in low socioeconomic status, you would see
Protein
that.
energy malnutrition.
Exactly. Yeah. That is also very important. So these are other 3 causes which you should keep in mind. Okay.
Yes.
Okay. Okay. So you can go.
Yes. After 5 to 6 days, mother has noticed generalized abdominal distension, which is insidious in onset and progressive. This is associated with decreased in frequency of urination, which is from 8 to 9 times a day to 5 to 6 times a day.
Okay. So the child age is 2 years, right?
Yes, sir.
Yeah. So what you would ask, so when you are telling about the frequency of urination, and writing 8 to 9 times a day to 5 to 6 times a day, it's okay, but I guess there is no accurate cutoff that every 2-year child has to pass this much of urine, or that child has to pass this. So usually avoid this writing, right? Like if you want to say it's an increased frequency of urine, it's good. You can tell that he or she is passing 200 times, 20 times. That is something we can tell it. But writing something like 8 to 9 times a day, we cannot say it is a normal. For some babies, it could be normal. For some children, it will be just they will pass 1 to 2 times a day, while other child will pass 4 to 5 times a day. It's depend upon the urine output, it's depend upon the fluid intake. If the child is not taking much fluid, it doesn't mean that if you will pass very less urine. That doesn't
Yeah.
mean that the child is having oliguria, right? So
Instead of
better
telling
avoid.
frequency, yeah, that volume of urine is more important.
Yeah, it's better don't write
Instead
anything.
of telling
Compare.
frequency.
Yes.
So
Yeah, go ahead.
go ahead.
There is no history of breathlessness on exertion, chest pain, palpitation, no history of recurrent respiratory tract infection and symptoms suggestive of orthopnea, weight loss, and no history of altered appetite, failure to thrive, jaundice, vomiting, and pain in abdomen, loose stools, blood in stools. No history of cola-colored urine, burning headache, blurring of vision, no history of fever, difficulty in breathing, hurried breathing, chest in drawing, and no history of bony pain, blood transfusion, skin rashes, joint pain, drug intake.
Okay.
Okay. Can you explain it? Why you ask these questions?
Is breathlessness
Yeah,
on
please.
exertion, chest pain, palpitation to rule out any cardiac pathology is there or not.
Okay.
And
Good.
recurrent respiratory tract infection, symptoms of suggestive orthopnea or weight loss, just to rule out respiratory tract infections or any pathology of respiratory system. Altered appetite, failure to thrive, which is for protein energy malnutrition, and jaundice for hepatic causes, vomiting, pain in abdomen, loose stools, blood in stools, to rule out GIT pathology. Cola-colored urine, which is for nephritic syndrome, to rule out a nephritic syndrome. Burning micturations for urinary tract infections. Headache and blurring of vision to rule out any hypertension is present or not. Fever,
Okay.
difficulty in breathing, hurried breathing, chest and drawing to rule out any infection like pneumonia is there or not. And bony pain for any malignancy, blood transfusion for hepatitis B infections, skin rashes for systemic lupus erythematosus infections. Then joint pain or any drug intake will cause nephrotic syndromes.
What drug you are expecting?
Penicillamine.
Okay. Penicillamine is given in which condition? Okay. So pediatric age group, Wilson disease is most common one. So penicillamine commonly used in Wilson disease. Apart from any other drugs can cause kind of nephrotic syndrome.
What is the most common drug we use for every children's? Like they're saying for fever, or we even use for pain, joint pain, if the child is coming for arthralgia, myalgia. In orthopedic, we use the drugs commonly. What is that drug?
Steroids.
Huh? Steroids. Steroids. You are giving treatment steroids only. It cannot be steroid that causes uh, nephrotic syndrome. Most common drug, even adults. It's commonest drug used in your orthopedic practice. I given it. Your NSAIDs, your non-steroidal anti-inflammatory drugs are also one of the commonest cause of secondary cause of nephrotic syndrome. So that has to be also ruled out.
So one more question you asked here, failure to thrive. So this edematous child, how to differentiate whether this is because of malnutrition or because of this edema?
If a child is because of edema means the child after the treating edema, the child will look dull.
Because this nephrotic syndrome or kidney pathology, that child absolutely normal before this edema presentation. But in failure to thrive, apart from that generalized edema, those will have that micronutrient and macronutrient and vitamin deficiency futures. Okay.
Are you getting the question what sir is asking you?
Yes, sir.
You are getting the question what sir asked right now?
Yes, sir. Failure to thrive.
Yeah, sir is asking failure to thrive. One is edema. In case of failure to thrive, as you said, it could be malnutrition. and malnutrition causing second nephrotic syndrome. So how this edema is because of nephrotic syndrome or due to malnutrition? How will you differentiate? So sir is telling that before the onset of edema, the child was there was no other illness. The child was absolutely normal for its weight for age and height for age. Then it's more likely because of nephrotic syndrome. Whereas even before the development of edema, the child was not up to the mark. His weight and height was below the standard deviation, and he was also having micronutrition deficiency like a vitamin A deficiency, like what you will see in vitamin A, carotid, would have conjunctivitis, cirrhosis. So like that kind of features if that is present, and air abnormalities. So if that was present associated with the edema, then it's more likely the edema is associated with the malnutrition, not because of nephrotic syndrome. So sir was telling that, right?
Yes.
Okay, then you can continue.
Yes. Past history, no such similar episode present in past, no history of hypertension, no history of tuberculosis, no history of measles, no surgical history.
So in
One
this
minute.
past history only, blood transfusion also you can include. Past history of blood transfusion that may lead to present illness.
Yes.
Okay, so what is the importance of asking history of tuberculosis here? Any relevance to the case?
It was latent infections.
Okay, latent infection. Yeah, I'm asking whether TB will cause nephrotic syndrome, or what is the point of asking tuberculosis in past history? Any relevance?
Any congenital infections is present or not. After treating nephrotic syndrome, the steroids will
That is
cause
the main reason.
infection, increase in
Before
infections.
starting steroid, we have to rule out any infection. Most likely in our country, TB is the most rampant disease. It's kind of a disease of India. It's a most common disease of India is your tuberculosis. So for any condition where you are going to prescribe steroid, you have to rule out any contact history with TB, and also you have to do Mantoux test, whatever we'll be discussing in upcoming slides. So that is the main reason why you're asking any history of contact of TB. And what is the importance, relevance of measles? You have asked this history of measles, but what is the relevance of asking measles in nephrotic syndrome? In this case, sorry, nephrotic syndrome. In this case,
Any infections is present.
yeah, I am asking whether measles can cause nephrotic syndrome.
No, sir.
No. Okay, but
Because
there
the
must
other
have
viruses can cause nephrotic syndrome, secondary nephrotic syndrome.
what are the diseases caused?
Infections will cause
What are the
secondary
infections?
nephrotic syndromes. Infections will cause.
Which infections? Name few infection which causes nephrotic syndrome, secondary cause of nephrotics. You asked about the history of blood transfusion, right? So what's
Yes,
the
sir,
indication of
hepatitis B.
hepatitis B and C? Yes.
Hepatitis B
Another thing?
infections. HIV infections.
Yes,
Yes,
very
sir.
good. HIV, good. And what is the endemic our country? What are the tropical infections which are common in our country? What are
The
the
most
common
common in Chennai.
Chennai? Malaria.
Malaria.
Malaria. That's very common. And as you say, congenital infection, torch infections.
Yes.
Yes, sir.
That are what are secondary commonest infection that leads to secondary nephrotic syndrome. In malaria, it's a plasmodium malaria. That is the most common form. Yeah, that causes. Yeah. And this history of measles is not that much relevant for this case, but you should know historically there was a 1960s and 70s, in order to treat nephrotic syndrome, this nephrotic syndrome children have been since, as you say, this nephrotic syndrome children are put in a ward with measles patient. Do you know why? So this relevant is not relevant to this case, but historically, when in the era of 1960s and 70s, the children who were diagnosed as nephrotic syndrome, they were put together with measles patient. The implication of this, because this measles has property to reduce your T cell immunity. It attacks your T cells, so it reduces the T cells. And you know that your nephrotic syndrome, one of the most commonest theory that is implicated in nephrotic syndrome is your T cell dysfunction. Because of this T cell dysfunction, the child will have this features of hypoalbuminemia, that is protein losing nephropathy. In order to prevent that, they kept these children along with measles, and most of the children responded to it. The nephrotic syndrome even recovered from nephrotic syndrome. But right now we are not doing that. That is one of the historical implication of measles and nephrotic syndrome, right? So you can carry.
Treatment history, the child was not on any medications.
Okay. Next.
Family history, non-consanguineous parents, no history of any renal disease or nephrotic syndrome in their family members.
So wait here. What is about relevance of nephrotic syndrome in family? What you are thinking about?
Genetical disease, congenital
Yeah.
diseases.
What is congenital nephrotic syndrome?
Congenital.
What is congenital
Alport syndrome.
What? Yeah,
Congenital-
tell. You can make mistake
Alport
here.
syndrome.
Yeah. What syndrome?
Alport syndrome.
Alport syndrome. Good. Alport syndrome. What is the triad of Alport syndrome? Along with nephrotic syndrome, what they will have? See, less likely the Alport syndrome as proteinuria, but more likely goes in favor of hematuria. You will have hematuria along with sensory neural hearing loss. Apart from Alport syndrome, what you will say for any name few other congenital nephrotic syndrome?
Dennis-Drash syndrome.
Good. Dennis-Drash, then
Lowe syndrome.
Lowe syndrome. Good.
Mm.
Most common, which is the most commonest congenital nephrotic syndrome. Finish type.
Finished.
You read it about finish type. Finish type, Dennis-Drash, and Frazier, Lowe. They are the other few commonest cause of congenital nephrotic syndrome.
In this case, the child age is 2 years. Are you happy with it? This child age is 2 years, no?
Yes, sir.
So, are you happy with this age group, or you want to worry about it?
Sir is asking what is the prognosis. Sir asking with this age, at this age the child is having, at 2 years the child is having his first episode. So are you okay with it, or you want to worry about this, or you can reassure yourself that it will not that much problematic to deal with. Which is good, have good prognosis. Congenital nephrotic syndrome or this syndrome, the nephrotic syndrome that occurs at the age of 2 years, 3 years, which is
very
a
good
good prognosis.
Most common age group is 2 to 10
to 5
years.
years.
Yeah, so 2 to 6 you want to say. So less than 1 year, usually we used to think about congenital nephrotic syndrome. Here is 2 years, no? So
yes,
that's what I asked. Okay.
Okay, then can go with so any congenital nephrotic syndrome, you name it when it is less than 3 months. Any child who present with this massive proteinuria, edema, and failure to try in less than 3 months, one of the commonest DD you have, or one of the DD will be your congenital nephrotic syndrome. Okay, carry on.
Antenatal history. The mother is a registered case. First trimester, spontaneous conception confirmed at 45 days of amenorrhea by urine pregnancy test. No history of fever with rashes. Dating scan and mutual transfusion scan was normal. Folic acid was taken. No other drug intake or radiation exposure.
Okay.
Second trimester, quickening is felt at 5th month. Iron and calcium tablet are taken. Anomaly scan is done. 2 doses of tetanus toxoid taken 1 month apart. No history of headache, documented hypertension, no history of polyuria, polydipsia, oral glucose tolerance test was normal. Third trimester,
Sorry,
fetal
so out
weight.
of subject. So 2 doses of tetanus toxoid you are telling, no? Whether it's tetanus toxoid or any other vaccine now is recommended in pregnant women.
I'm not sure.
No,
So now that
Sir is asking whether TT we are giving right now or other combination of tetanus we are giving. What is the recent recommendation by the government of India for this maternal vaccination? Which vaccination is recommended right now? Tetanus toxoid is right now, it's not recommended. Instead of we are giving another thing. What is that? Sir is asking that. You know TD, tetanus diphtheria. We give TD.
Yes.
Okay, small t, small d. We are giving
Yes.
that instead of TT. That has been recommended in 2019 by Government of India. So it has been removed. Ministry of Health and Family Welfare right now recommends TD instead of TT. Same 1 month apart. What is the dose is all same, but we are just changing the vaccine. Okay. So sir is asking
Yes.
that one. Okay. Yeah.
Third trimester, fetal movements is well. Growth scan is normal. No history of pregnancy-induced hypertension, gestational diabetes, urinary tract infections.
Good. Then
Birth history, the baby was delivered by LSCS at term in private hospital. Birth weight is 3.5 kg. Cried immediately after birth.
okay. Whenever you write out the LUCS, always ask the indication. You have to write the indication. This is very important. Not for this case. I'm generally, if you are creating any condition which is beyond, which is not a normal vaginal delivery, it could be an assisted vaginal delivery in the form of your instrumentation, forceps or vacuum or LUCS, whether it's an emergency LUCS and elective LUCS. Everything is very important in terms of why it was done. So you should know the indication. Birth weight is quite normal for 3.5 kg baby. It's more normal in an Indian scenario. And what is the other issue which is very relevant for if you are thinking about congenital nephrotic syndrome in birth history, what is this which give a very important clue that the child may have a congenital nephrotic syndrome?
Preterm baby.
What? Preterm?
Preterm baby.
Yeah, good. Preterm one is it's one thing. Preterm, yeah. Then most commonly, which is you will see. Mostly we don't ask that question, but that is one of the important feature to tell that the child may have a congenital nephrotic syndrome. Placenta, placentomegaly. If there is a placentomegaly, it's commonly associated with a Finnish variant of congenital nephrotic syndrome. So that given clue that this child may be a case of congenital nephrotic syndrome, right? Okay.
Yes. Postnatal history, breastfeed within 30 minutes after delivery. Baby passes meconium and urine within 24 hours of birth. No history of neonatal intensive care unit. No history of breathlessness, jaundice, fever, convulsion, bluish discoloration.
Okay. Okay. Okay.
Diet is
Carry on.
Diet history is mixed diet. Time morning food items was dosa, one amount, calories 100.
You don't need to tell that. What is the total calorie requirement for the child and now how much is getting and what is the calorie deficit? You tell that, yeah.
Yes, sir. Well, calorie required is 1200 kilocalorie. The child consumed is 870 kilocalorie. So deficient is 330 kilocalories.
How much child weight here?
What is the weight of the
I'm
child?
asking.
That is asking weight. No, what is the weight of the child? Hello.
Hello.
You go and see what is the weight of the child.
Yeah, I put it in anthropometry, sir.
Okay, okay, fine.
Okay. So how do you calculate the calorie for the children? What formula you use?
I use the tables present.
What?
I use a chart present.
Okay. But what is the simplest way? If you don't have any chart, then what you will use? With just you know the weight of the child, then how do you calculate the total required calorie for that particular child?
For
What? I'm asking if you don't have any chart, you just know the weight of the child. Now, how do you calculate the required calorie for the child? That means what would be the required calorie? How would you say that this is the calorie the child must consume per day? And you just know the weight of the child.
is based on the age of the child.
No, yeah, okay. With that, I'm asking you with the weight. How do you calculate? You know Holiday-Segar formula? Holiday-Segar formula.
Is
It's used for
how much
it's used
calorie
for
intake for
exactly. So for first 10 kg, how much for first 10 kg, how much it will calculate? How much it will give?
1000 kilocalorie.
That means for every 1 kg, it's 100 kilocalorie. So 10 kg,
Yes.
it comes as 1000, right? Then for 10 to 20, what is the requirement?
For each
Then
kg
from
increase plus 20 calories will be increased.
no, no. For this not 20, it's 50.
50.
50. 20 to 30, it's 20. So with your required calorie 1200, we assume that child weight is around. So what this 1200 calorie means? What would be the weight of the child according to your calorie? 1200. It's more likely 14 kg. Yeah, right? If you
Yes.
take 10 kg as 1000, then after for every kg you can add 50. So total 1200, it gives most likely the child weight is 14 kg.
Yes.
So we will see what is the actual weight. So as we assume that your child weight is 14 kg and you say the requirement is 1200, but the child is taking 870. So total deficit is 330. So what is the minimum deficit you can allow with percentage? Like this plus or minus, we can accept. If that is beyond the plus or minus, then we have to treat that deficit.
Less than 15th percentile.
No, you are talking about a chart. I'm asking about the deficit. So when you say 330 calorie among 1200, this deficit we do a percentage. If it is within plus or minus, I am not sure. It's plus or minus 5%. To we can adjust. We can say that okay, this deficit is we can accept. But beyond that deficit, if he's taking less, if that percentage is coming to 8 or 10%, then that we have to treat. Then we have to correct that deficit, or else the child will go for malnutrition. Right? Okay, about the protein. So, how much protein a child should consume? How do you calculate the protein requirement for that child?
1 milligram per kg.
No, it's 1 correct, but not milligram, it's a gram. Because you are required all gram. So it's 1 gram per kg per day. Simple. So what's the weight of the child?
14 kg.
Actually, I should see your weight because 2 years baby, 26 grams is too much protein. Okay, we will see that. Okay, so the 26 gram, how come you came for this 26 gram? With the chart or by the calculation of by weight, into weight per day?
The chart.
Which chart it's given for 2 years, 26 gram? Which chart you follow, man? நீங்க எந்த chart follow பண்ணீங்க? இல்ல நீங்க I am asking which chart you follow?
IEP chart in net.
Okay, revise that one again, but unlikely
Yes.
this baby requirement is 26 gram.
26 grams too much for this child. Okay, see, இங்க mistake பண்ணலாம். அதால கேட்டேன். என்ன எந்த chart follow பண்ணீங்க? Always follow NIN chart. What is this NIN? NIN. NIN.
Yes.
Do you know what is the full form of NIN? National Institute of Nutrition. So they recommend a required daily requirement allowances for children, adults, for all age groups. So if you want to follow any chart, you should go with that chart. That is only accepted chart in our country. You don't go to the net and net have many charts. Okay, so in exam, always follow NIN or ICMR chart. Simple. It is available in your net. You go with that, and if that chart is plus giving this by coin, then you can substantiate in the exam. You cannot substantiate this with any other chart which is not recommended in our country. Only the ICMR guidelines and your NIN, National Institute of Nutrition guidelines, must be followed for any calorie and protein intake if you're going follow with the chart, or else with the weight, what we told about Oliver Sager's formula or 1 gram per kg per day, that should be followed. Okay?
Yes, sir.
Okay, you can go for next slide. Okay, all developmental.
Can you explain what are the milestones will be achieved by 2 years child?
Only
Gross
what
motor, fine
for all
motor.
the
Gross motor, well, the 2-year child can able to climb the stairs with 1 feet.
Okay.
Okay.
Good.
And fine motor, the child can able to draw the vertical lines or horizontal lines.
Okay.
Then
Or
what about the
language domain. The child can able to speak in fluid language with meaning.
Yeah, okay. That is to fluid level is they will make a sentence of 1 to 2 words, right? You will make
Yes,
sentence
sir.
with 1 to 2 words. That will be meaningful sentence. He will know, or even the grammar will be somewhat okay. Compare. That is one thing.
Yes.
What about the social?
Social history.
What? I was asking social milestone.
Yes, sir.
At 2 years, what social milestone will be achieved?
Child, at 1 year, the child will be waving dance, and at 2 years, I'm not sure, sir.
Okay. Okay, so developmentally, if the child is normal, then in development domain, you are asking social milestone, and another is your language and your cross motor and fine motor. Apart from that, what is the other thing we will be seeing? This is the only thing we will see in the development. Apart from that, any other history is important in developmental history. Normally, when you are writing development history, you write all the 6 domains. That is 6 domains, not 4 domains. What are the other 2 domains which we should have been mentioned here? One is gross motor, another is fine motor, another is language, fourth was social. Then 5 and 6, vision and hearing. That is also very important. So you should mention vision and hearing also. Okay? Okay. Okay, next, you can carry on.
Immunization history. Immunized up to date according to national immunization schedule. VCG scar was present. Optional vaccine is not taken.
So here, what are the optional vaccines at 2 years up to this year?
Hepatitis A vaccination.
Very
Haemophilus
good.
influenza. Varicella vaccine.
Good.
Plus influenza.
Yes, sir.
So that is covered by national immunization schedule also, no? 6, 10, 14.
Haemophilus influenza is the
Okay. Varicella is good. Okay. And influenza vaccine.
meningococcal vaccine.
Yeah, very good. Meningococcal. Then influenza, flu vaccine,
Yes.
Okay.
and
Okay.
typhoid.
So, typhoid.
Yes.
Good. So why these vaccines are very important, especially for this kit?
To prevent any infection, VCG vaccine is given to prevent the tuberculosis infection.
Okay.
Hepatitis B vaccination is given to prevent any blood transfusion or any
Okay.
vertical transmission disease.
Now, this child, whether the child received adequate immunization or not, we should know, because we are going to start long-term steroid therapy. So the child will become immunocompromised. So that's the reason the child should receive adequate immunization, or else we need to provide vaccination at appropriate time, post immunosuppression therapy treatment duration time.
Okay. So question is, another thing is, for what other organism you want to give vaccine? Which organism is most commonly the children are prone, and why?
Streptococcus infection, staphylococcus aureus. Gram negative.
Streptococcus, which type of organism the children have risk for developing infection? Despite if you start steroid or not, that doesn't matter, but this organism, they may cause severe infection. So what are the organisms? Name few organisms. And for that, we do give vaccinations.
Gram negative bacilli or
Okay, gram negative. Okay, then there is one word specifically. This words it's given in book. So I'm asking that.
pneumococcus. Pneumococci vas.
Yes, good. Pneumococcus.
Then streptococcus.
Meningococcus, pneumococcus, H. influenza. So what are these organisms? They are broadly called as encapsulator organisms.
Yes.
Why this encapsulator organism children are more prone for infection? What is the reason for it? Why these children? Yeah. Why they are more prone?
Because it is encapsulated infection.
Okay.
So
So in order to have this encapsulator organism, so what are the reason why they are more prone for infection with this organism? So what are the points that tells this nephrotic syndrome children are at high risk of infection because they have this following points in favor for this organism to capture and they cause the severe infections? What happens in nephrotic syndrome? What is the
loss of proteins.
What are the proteins? What are the proteins that are lost?
Immunoglobulin,
Good. Immunoglobulins. Another?
antithrombins,
Yeah, that is another protein.
transaminases.
Good. Transaminases, no, don't go with that. I'm asking irrelevant to the infection, irrelevant to your immunity. One you said very good, immunoglobulins. Another? Your complements are lost. And there are alternative complement pathways like your protein, factor B and B, and they activate your propertin pathway. And what is important, this pathway, this propertin pathway is very important for this encapsulated organism because they help in a process called opsonization. What is called as opsonization? What is opsonization? Any other student is present here? Yes, another student is there, Shakti Ram. You can also participate. If you know the answer, you can also unmute yourself and answer. Shakti Ram and Parthiban, you can also answer. Yeah. So what is opsonization?
Opsonization with the antigen-antibody reaction.
Seems somewhat you're close to the answer, but the thing is, opsonization is a process where the complement will form a coat over this organism, which I said pneumococci, meningococci, H. influenza. Since they are encapsulated organism, they they have a strategy to evade all your immune system. So they cannot be directly attacked by your macrophage. In order to get attacked by the macrophages, this organism has to be get encoded with all the complements and factor B and D, which we told. Once they are being encoded, they will be recognized by your macrophages, mainly your splenic macrophages. The splenic macrophages are mainly responsible for all this encapsulated organisms. So when there is a proper opsonization, when they get coated with this all this protein B, a factor B and D as well as a complement, they get easily recognized by the splenic macrophages and they get easily destroyed. So when this process is not going to happen, in one is because there is no complement, it is lost, or in a splenectomy patient. That's why in even a splenectomy patient prior to splenectomy, we give this all vaccination. So that is the reason why we have to give this mainly a PCV meningococcal H influenza vaccine to this patient. So that is the reason why so you should know what is the concept behind this, why we are giving this vaccination for this patient. Okay?
Yes.
Okay, you can carry on.
Summary,
Okay.
sir.
Yeah.
2-year-old child born to non-consanguineous parents with full-term baby, LSCS belonging to class 3 Kupusamy scale. All developmental domains are achieved and fully immunized. Dietary deficiency is present. Was brought to OPD with complaints of puffiness around the eyes and face for 3 weeks, progressing to involve bilateral lower and upper limb for 2 weeks. Abdominal distension is present for 1 week. The history suggestive of edema of renal origin, likely to be nephrotic syndrome, most probably minimally changed nephrotic syndrome without any complications.
Okay. One thing is, two things I would be asking you. One is, you told, okay. What do you mean by fully immunized child? What is complete immunized child and what is fully immunized child? When you say the child is fully immunized and when you say the child is completely immunized.
When the baby complete the vaccine up
You
to
wrote fully immunized, right? What that does mean? What that terminology mean that the child is fully immunized?
the vaccines up to 2 years of age.
Very good.
is
Exactly.
completed.
If the child has completed the vaccination up to what or recommended by your national immunization schedule. We are not talking about IAP. We are just talking about the national immunization schedule. If the child has taken all the vaccination that has been recommended by your Ministry of Health and Family Welfare, Government of India, till 2 years, then you say the child is fully immunized. Whatever complete immunized?
All the immunization is given, which is present in national immunization schedule.
What is about the complete? When you use the word complete, you wrote full. Full is for 2 years. What about the complete?
Complete is up to 5 years of vaccination.
No, we don't go for 5 years. It's 1 year. 1 year. If the child is taken all the vaccination that has been recommended by your national immunization schedule till 1 year without any delay, then we say it as completely immunized. Fully immunized for 2 years. So you should know each and every terminology. Here, that's not a problem, but when you are presenting in exam, the examiner will ask question from each and every word which you are presenting to him. So you should know why you are telling that particular words. Okay, that's why I'm asked what is fully immunized and completely immunized, right? Okay, so you said that the child is having the edema of external genitalia, right? So that's since a male says it's my penile edema or scrotal edema. So what that signifies? What the genital edema signifies in this case?
Shifting of fluid is taking place.
What?
Shifting of fluid all over the body is taking places.
Okay, it's simple. Everywhere, bilateral lower edema, upper limb edema, abdominal distension, same thing is happening. Everywhere, the shifting of third space loss is happening. So it's not that specifically genitalia, in genitalia only that shifting of fluid happening. But what that signifies? When a penile edema or external genitalia edema is happening, it signifies some very important thing. What is that?
Hydrocele.
No, hydrocele is
Inguinal hernia.
Huh? It tell about the severe protein loss. It's tell about the hypoalbuminemia. It indirectly tell that the albumin may be less than 2. Whenever a child is having a severe, if the child is having an external genitalia, it's not that all cases will have this less than 2, but mostly it has been seen. Any child who's having penile edema, vulval edema, or scrotal edema, that serum albumin most likely goes in less than 2 grams. So that is the importance why the genitalia edema is important. So do you have to see the serum albumin level? And if the serum albumin level is very low, less than 1.5, we have to give an albumin infusion for the child. So that's the importance of seeing genital edema. It given without doing blood investigation, you can just have a guess that maybe the child's serum albumin is less than 2. So that is the importance of seeing the genital edema. Okay. So you say the history is suggestive of edema of renal origin. You already explained your history, and sir has also asked. Then you told me that the child is having renal edema, hepatic edema, as well as your angioedema and your cardiac edema. So you have ruled out, and you are saying this is renal edema. So renal edema, how it progress? So how do you say this is a renal edema? With the history itself, you are told. So you just again you tell so that whoever is watching, they will know what is the difference between the renal edema, hepatic edema, and cardiac edema.
For renal edema, the edema will be more prominent in periorbital regions of the eye and faces. Then it gets shifted into the upper limbs and lower limbs, and abdominal distension is present. In cardiac pathology, first the edema is seen in limbs such as pedal edema, and in hepatic pathology, the abdominal distension is first seen.
Okay, so other causes of edema, apart from that, which we already told, what are the other causes? As sir already told you, you just again you recapitulate.
Angioneuropathy, protein energy malnutrition.
Angioedema, any allergic history. Because of any allergy, there will be urticaria and there will be third space loss because of the allergic reaction. That is angioedema. Another thing?
Protein energy malnutrition.
Very good. Protein energy malnutrition, protein losing enteropathy. That is another thing. Another thing as a hypothyroidism. We have mixed it. So, okay. So then you say about it is a likely to be a, so as the history suggests, it's most likely go in favor of nephrotic syndrome. Good. Sorry, renal origin. Now tell me how you are saying that it's most likely a nephrotic syndrome. Why not nephritic syndrome? Why it could not be a nephrotic syndrome? Nephritis, sorry.
In
Tell me
nephritic
from the history.
syndrome,
We are not talking about, see, we are not talking about examination. We have not gone into examination. Just by the history, how do you tell it is a nephrotic syndrome, not nephritic?
in nephritic syndrome, hematuria will be present, mild proteinuria is present. First, oliguria will be seen, then edema is seen, which is mild. In nephrotic syndrome, there will be massive edema and massive proteinuria is seen, and there will be hypoalbuminemia is seen in nephrotic syndrome.
Hypoalbuminemia is seen, you cannot say right now. Here, we are just talking about history. We then gone to examination or lab investigation. Well said. You said about the. So always start from age. Okay. In nephritic syndrome, it's the school age children, around 8 to 10 years or 5 years to 12 years in that age. But here it's a small age, 2 to 6 years. Any predisposing factor, most likely nephrotic syndrome, you say any upper respiratory tract infection, followed by that the child after 1 to 2 weeks, the child will start to have the edema, developmental of edema. And here it's always what type of infection will cause this nephritic syndrome?
Streptococcus infection.
Very good. What infection? Streptococcal? Where? They are more predisposed.
Lower
In which
respiratory.
region? Yeah.
Lower respiratory tract infections.
No. It's like any two specific infection that predisposes to glomerulonephritis. PSEN, post-streptococcal glomerulonephritis, which is we call it as a nephritic syndrome. Your pharyngitis, streptococcal pharyngitis and streptococcal pyoderm. So they are the two most common infection associated with development of the nephritic syndrome. So they will be more commonly seen in the nephritic syndrome. So in the children who develop nephritic syndrome, they will have some kind of rashes. They will have some healing rashes over the limbs. So that itself tells that the child may be suffering from nephritis. So this is one of the history. And you said about proteinuria. Proteinuria massive will be present in your in the case of your nephrotic, whereas it will mild in case of nephritic. Hematuria, cola colored urine more favor of nephritic. It's less likely here. In any hypertension, if the child is having hypertension, that's always go in favor of nephritic. Less commonly in the nephrotic. Sorry, in your nephrotic. So this is all the findings with that. So in the child, it's most likely, as you said, there was no, there's an edema, progressive edema. There is also oliguria developed after edema. As you said, nephritis syndrome is always your oliguria develops first, then only the edema develops. So in that way, it's go in favor of nephrotic. So the age, 2 years, massive edema, then the oliguria developed. There was no hematuria, there was no hypertension per se. There was no loss of blurring of vision or headache that itself tells that the child is not having that hypertensive complication. So more likely the child is having nephritis. So you told the edema is because of renal origin. It's because of nephrotic syndrome. Most probably MCNS. So how do you say that is most commonly MCNS? Why could there be other pathology? Why it is MCNS?
In nephrotic syndrome, 80% it will be minimally changed nephrotic syndrome.
The thing is, never comment any pathology in summary or in your history because you didn't examine the patient, you didn't do any lab investigation without doing anything. Just because most common, okay, you can't go, but better avoid telling MCNS here. You can tell in your provisional diagnosis and different in your diagnosis part. In summary, till nephrotic syndrome, you can tell, right? So the history suggests of edema of renal origin likely to be nephrotic syndrome. So I would like to examine what system?
Renal.
Renal system. Is there any system called renal system?
No, sir, GIT.
Yeah, gastrointestinal syndrome with genitourinary and GI system. Simple. You say genitourinary and gastrointestinal. Just tell that. Don't tell the child is suffering from MCNS, probably MCNS, which you cannot tell just with the history. MCNS cannot be told. It's just for telling the child is suffering from MCNS, what you should do?
Biopsy and
Yeah, exactly. You should do a biopsy, right?
microscopy.
Yeah, microscopic examination. You may tell it in a diagnosis, but avoid telling it in summary. Till nephrotic syndrome, you tell, and then I would like to examine the genitourinary system. Okay?
Yes, sir.
Okay, you can go for next. Yeah. So we completed till summary. Then we'll go for the examination. Okay.
Under examination, child was conscious, cooperative, and well-oriented to time, place, person. Generalized edema was present in facial and periorbital puffiness. Abdominal distension, upper and lower limb swelling is present. No palar, icterus, cyanosis, clubbing, lymphadenopathy is present.
Okay. So for time being, I'm not telling it, but whenever you're talking about edema, you tell me this. You know what the grading of edema? Hmm?
No, sir.
Okay. So you should know grading of edema, at least low limb grading of edema. Up to ankle, it is grade 1. Ankle to knee, it's grade 2. It's involved the whole limb, it's been grade 3, and grade 4 means anasaka. Simple. So you have to tell that edema. Generalized edema means it is grade 4. So it is a grade 4 edema. So you should know the grading of edema. That is important for the nephrotic syndrome. So you should mention it. Okay. Then no pallor, icterus, cyanosis, clubbing, and impediment. Okay. So how would you check pallor in a nephrotic syndrome child? What is the area you should evaluate for a pallor?
Palpebral conjunctiva.
Yeah, palpable conjunctiva is the most common thing we see in any case. But in this case,
And
whether
nail.
Yeah,
Nail beds.
nail beds are another areas.
Mucosa of mouth.
Mucosa, okay, then which mucosa you will see? Your oral mucosa and any other thing, tongue. Your tongue also you can take. So you see see for three criteria. One is palmar erythema. We see a palmar pallor, conjunctival pallor, and another one is tongue in your mucosa. We grade have 3 grades: grade 1, grade 2, grade 3. Only conjunctival pallor is present, it is grade 1. If conjunctival plus tongue plus or minus with palmar pallor, that palmar pallor is something outside the hypotenuse is pale, but your this creases, the palmar crease is not pale, that is moderate. When the palmar crease is also get pale, when there's a paleness in the palmar crease, then it's known as severe pallor. So we have 3: mild pallor, moderate pallor, severe pallor. Mind it that in case of nephrotic syndrome, any child with severe edema, the palpable conjunctiva may be falsely pale. The paleness is not because of anemia. There are other causes of paleness. Okay, the cause of pallor is not synonymous with anemia. This you should know. Any child you are telling the child is pale, it doesn't mean the child is anemic. In hypothyroidism, the child's this can be a pain. It's also because of anemia. It's also because of many other things. Another one most common is edema. Edema, even why the edema causes paleness?
Because fluid gets shifted to intravascular spaces. So
in yes, exactly. Fluid gets shifted to the extravascular phases. So what it does, that will get edematous. So tissue will get stretched out. So when you go for palpable, when you see the palpable conjunctiva, since this edema fluid get shifted to extravascular space around the vessels, so it will stress out. When you're stressed out, your capillaries get stressed out, and it gives a false paleness. This paleness doesn't correspond to the anemia. So that's why any child with edema don't see palpable conjunctiva. If you see palpable conjunctiva, it gives a false paleness. This paleness is not because of anemia, it's because of the edema. So always avoid seeing conjunctival pallor in the cases. Okay?
Yes.
Okay. Then you can continue.
Vitals, temperature 98 Fahrenheit, pulse 98 beats per minute, good volume, regular, no delay, all peripheral pulse are felt, respiratory rate 32 per minute, blood pressure 85 by 50 millimeter per mercury, right upper limb in supine position.
Okay. Okay. Good volume. If the child is tachypneic in this case, okay, the child is not having fever, but there is tachypnea, what would you suspect? If the child respiratory, what is the age of 2 years? The child age is 2 years. So what is the normal respiratory rate for the child?
23
What is the
to
normal
37. 23 to 37 per minute.
20?
3 to 37 per minute.
Okay. So as per WHO grading, what are the grades of tachypnea? In WHO, for particular age, what is tachypnea? You said it's the child is having tachypnea for less than 2 months, 2 months to 1 year, 1 to 5 years. You know, right? More than 60 in age less than 2 years, more than 50 in age less than 1 month, 2 months to 1 year. From that 1 to 2 years, if it's more than 40, after 2 to 5 years, I guess it's more than 30. So if the child falls in this criteria, then the child is having tachypnea. Here the child is having respiratory rate of 32. So more likely the child is age is 2 years, right?
Yes, sir.
So what are the causes of tachypnea in this child? If I am taking the child is having respiratory rate of 45. So what is age group? That is tachypnea. So if the child is having tachypnea, so what would you see? So what would be the cause of the tachypnea?
Due to ascites,
Very
the
good.
diaphragm
So
will
why
be
ascites causes tachypnea?
increase in fluid which cause pressure on diaphragm, which
Yes,
leads
it
to
will push the
pressure on
diaphragm upward. As a result, the child will have a difficulty in breathing. Very good. This is one of the most important cause because your child was having ascites. Yeah, ascites. So that may be one of the cause. Then another.
anemia.
Good. Anemia. Yeah. Anemia, if the child is having a severe pallor, the child may have breathing. But what is that breathing cause? The anemia causing breathing.
Anemia causes decrease in RBC count which cause hypoxia and
Okay, one is hypoxia, but what is the
dyspnea.
other one? One is hypoxia, what is the cause apart from that? Acidotic breathing. Because in anemia, you have hypoxia, the cellular mechanism goes in from aerobic to anaerobic, there will be lactate production, there will be acidosis, this acidosis will cause acidotic breathing. So anemia. In this child, I guess it's less likely to be anemia. So that is somewhat last option we can keep. Before that, any other thing you have to rule out in this child?
With thrombosis formation.
Thrombosis can tachypnea. Okay, what thrombosis causes tachypnea? That's all very least. One of the most traumatic complication presents. Okay, where? In where you will see that this kind of thrombosis.
Pulmonary involves.
Very good. Pulmonary thrombosis. Yeah, pulmonary thrombosis may cause tachypnea, but we will keep it as one of least. Before that, what we have to rule out, I must say. They are more prone for infection. So they may get respiratory tract infection. They may have pneumonia. That may increase the tachypnea, or they may have third space loss. If third space loss occur in lungs, it's known as pleural effusion. So even a pleural effusion causes tachypnea. So most commonest cause of tachypnea in a nephrotic syndrome, first is your ascites, which cause pushed up diaphragm. As a result, the child will have difficulty in breathing. Second is your pleural effusion because there is third space loss because of hypoalbuminemia. And third one is pneumonia because they are more for infection. These lateral causes associate pulmonary thrombosis because of thromboembolic phenomena and anemia, severe failure if it is present. Then you can. These are the causes of tachypnea in a child with nephrotic syndrome. So go with the case. That will be very useful to tell that the child may having this sort of. Okay, BP. So BP is 85 to 50, right?
Yes, sir.
So normally, what is the normal BP for the child for the age 2 years?
For systolic is 86 to 106. For diastole, it is 42 to 53.
So you got it from a chart.
We need to follow the centile chart of blood pressure. That is for age as well as that length and sex of the child. These are all the three references.
So if you go and see your OPCI book in hypertension chapter, they would have a big chart, blue color chart for boys, pink color chart for girls. They will be giving 1 year, 50th centile, 20th centile, 50, 70th centile, 8, 90th centile according to the height. In that particular sequence, they will give some number of pressure, systolic blood pressure, diastolic blood pressure. If that has to be calculated, and that will tell you that this child's BP is high or not. So in that way, you have to just because the number like what you see in adults, 120 by 80, 130 by 90, 140 by 90, that stage one stage, that is not going to follow here. We follow that chart. So go with the chart. Right upper limb in supine position, you check it. So with the help of at the level of always right at the level of heart, you have to calculate. You have to take record the BP. Okay. So
and one question I want to ask you. So, like one nephrotic child, you diagnosed, you admitted in the hospital, that child on treatment, receiving some fluids. Suddenly, the child is having breathlessness. So, what you will think about that time, whether it's because of volume overload or hypotension? How to differentiate these two?
Because of volume overload.
Either it's because of volume overload or hypovolemia. Both will have breathlessness, tachypnea, tachycardia, especially in like this child. So, what is the key clinical sign or marker to differentiate to hypovolemia or hyperolemia? So it's simply like child whenever in hypovolemia, it's kind of shock presentation. Okay, peripheries are cold, blood pressures will be lower side. But in same child receiving excessive amount of fluid, the child BP will be normal.
High, it will be high.
Okay. So these things you should keep in mind whenever you are admitting nephrotic syndrome in ward or ICU.
Yes, sir.
Okay. So next, it is everything is normal. It's observed anthropometry, weight, length, BMI, height, its circumference, MUAC mark.
Here you said 11 kg na weight. That's why we asked about that requirement of calories and proteins. So always your expected weight and expected protein should match this baby's weight. Okay, so lot of discrepancies there means whether you ask properly or not, it's questionable. That's why I always correlate with baby weight as well as that requirement.
For yeah, for 11 kg baby, you cannot give a 26 gram of protein. That's too much for him. We just recommend till, yeah, we can go up to 15 gram. That's good, but giving more protein is also harm for the baby. So 26 gram is too much for that child, for a 2-year child. So that's the reason why we ask. Even it's given in a textbook or there is no recommendation that you have to give like any chart. So always go with this NIN chart. But I am that's why I asked with the weight. You should know the weight, and according to the weight, that would be very simplest calculation. Because most of the examiner will know that particular formula. So going with the chart, then you have to say this which chart you are following. Only ICMR and NIN, that is National Institute of Nutrition. These are the only two charts which has been recommended by our government. Any hospital, you go, this is the chart you have to follow and you have to tell in the exam. Then they will accept it. Or else you tell from other chart, it will be somewhat difficult to substantiate your point to them. So that's the reason we are telling. So it's very easy to go with the weight. With the weight, you calculate the calorie and protein, and it's very easy for you also. It's very simple. It's not that much Herculean task for writing the protein and the weight, protein and calorie for it. So now this weight, you said is 11 kg, and you are expecting 12 kg, right? The expected weight is 12 kg, but the child is 11. Now you tell me whether this weight is the actual weight of the child. The 11 kg is the actual weight of the child, or what you want to reframe, or you want to refine the weight.
11 kg is the actual weight of the
Actual
child.
weight.
So
Just think
yes.
about it. Think about it. Your child is a case of what?
Nephrotic syndrome.
Okay. Or okay.
Child, same child. Tomorrow, if you check weight, that same child is 13 kg means that is actual weight of the child or something.
Weight
So
get
you should know.
the flu.
Yeah. Good.
Very good.
See, this is a edema weight. This edema weight is not the actual weight of the child.
Yes, sir.
It is the.
So
It's
that's
not
why you should always ask pre-illness weight. Okay.
Exactly.
So whenever the child is having mild edema, like mild edema means genital, like vulval or scrotal edema, very minimal, then you can consider 7%. Then if significant, like moderate edema, you can consider 7 to 14%. Whenever that breathlessness, huge amount of edema is there, then you should think about some other reasons also. So this edema as well as the percentage will guide you regarding the treatment, whether that baby required oral Lasix or IV. That's the reason weight is more important, and every day you need to check the weight.
Exactly. So for these cases, you have to take everyday weight, abdominal gut measurement, weight measurement, and fluid intake and output. So that per day you have to calculate the weight loss, weight gain. If the baby is going with a sequentially every day there was a progressive weight gain, then yeah, there is a accumulation of fluid. It's going, the child is deteriorating. Then we have to see what is the cause. So what are the things we have to do? We have to give oral furosemide or IV furosemide. It's so in that way. That's the reason why every day, each day, your weight, fluid intake, and your abdominal gut. These three things are also the urine out. These four things has to be calculated every day on everyday basis so that you can you can see the progression of the disease, whether the child is improving or the child is deteriorating. With that, you have to change your treatment. So that's the reason why you have to measure this quality. So as per you, everything is normal. So I will say that with the weight you told, don't go with this a normal, I guess, because the child is having edema weight. With this edema weight, I guess you cannot say the inference as normal, and always follow your WHO or IAP growth chart. You should calculate the Z score. You should plot in the chart. Without plotting, but because you are expected with all the old formulas you used given in book, it's just for your theoretical knowledge. That is not going to be helping in the exam. The examiners will not be happy by seeing these values as normal without seeing the growth chart. They will always ask you to plot that everything in the growth chart and tell the Z score or centile. With that centile or Z score only, you can tell, you can infer whether the child is normal for that age and sex, or else you cannot tell it. So this you have to change. Inference should be based upon only on growth chart, not on any formulas which has been given in book. That is just only for theoretical knowledge. In reality, we go growth chart only. Growth chart must, and you should plot in the growth chart. And with that, you have to inference whether this child is appropriate for his age and his gender. Okay.
Yes.
Okay. Carry on.
8 to 4 examination. Head normal in size and shape. Face, periorbital and facial puffiness is seen. Oral cavity, no ulcer, fissures at angle of mouth and lips, no cleft lip and palate, no gum bleeds. Eyes, no pallor, icterus, phytoid spots or cataract. Ear, no discharge is present. Nose and nasal cavity is normal. Neck, no enlarged lymph node and rashes is seen. Chest, no rachitic rostri and Harrison sulcus, Fijian chest. Umbilicus, which is in normal position and stretched. Abdomen is distended. Genitalia, the scrotum appears normal. Spine is normal. Skeletal system has no deformity.
Okay, for skeletal system, and just for academic purpose, not theoretical knowledge only. In what type of nephrotic syndrome will you see the skeletal system abnormal? You are already told one thing. You are in his few things. Let's see. Just for theoretical knowledge, any skeletal system abnormality associated with nephrotic syndrome?
Vitamin D deficiencies.
Good, very good. If the child is on steroid, if the child is already on steroid, and other one thing is you will have rickets kind of presentation because they will lose that protein binding, vitamin D binding proteins. As a result, they may develop rickets if they have a chronic nephrotic syndrome case. That is one thing. Another thing is your nail patella syndrome. If you go with congenital syndrome, there is one condition called nail patella syndrome, where there is an absence of patella. That is also one of the variant of your congenital nephrotic syndrome, and that is a spino-osseous another variant that will also have some associated with nephrotic syndrome. So they are just I am discussing this as a theoretical knowledge. That's not that implicated in practical, but in case of a theory, it is helpful. Right? Okay.
So apart from nephrotic syndrome, you need to look for secondary causes of nephrotic syndrome.
Exactly.
Signs and symptoms in general examination. Like in skin, what you look for?
Any rashes is present.
Especially where? Skin rashes? At which place?
Where you will see you so what is the other cause? You said secondary nephrotic syndrome, rash. So what disease you are suspecting?
Very good.
Varicella zoster disease.
Varicella zoster. Okay. Apart from that,
Systemic lupus erythematosus.
exactly. SLE. Where you see the rash? Where you see the
malar rash, na?
Exactly.
Yes.
Malar.
But that's very unlikely in 2-year-old kid. But for older kids, you can. But this 2-year kid, maybe sometimes chances of HSP, initially purpura. That rash is usually seen in legs as well as buttocks.
Yeah. So these are the things for the secondary causes of nephrotic syndrome. You have to. Okay. Next. Okay.
Systemic examination, abdomen, under supine position, inspection, abdomen is distended and flanks are full, umbilicus is in midline but pushed downwards. All quadrants move with respiration, no scars, superficial dilated veins, no visible peristalsis and pulsations. Perineal orifices are normal. External genitalia, scrotal and penile edema is absent.
Okay. See, okay. In abdomen is distended and flaps are full. So what does that means? The flaps are full. What that implies? What does that implies if flaps are full?
Ascites or fluid is
Exactly. Acid is present. That is some kind of fluid collection is present. That's the importance of flaps fullness. Okay, that's one word. The umbilicus is in midline, but it is pushed down. But what is the characteristic of umbilicus? How it is? It's whether it's everted or it is inverted or it's kind of transversely slit like what? What type of character the umbilicus is?
It
You
is
should mention that.
everted. Yes.
Everted. So that is a massive ascites. Why you have to ask? You have to tell it because it tells of the amount. If it is everted, means there is a massive collection of ascites, fluid in the abdomen. Okay, that's everted in midline, but pushed down. So what does that imply? Pushed down means and pushed down. If the umbilicus is pushed down, what does that signify? And if umbilicus is pushed down, what does that imply?
Umbilicus is pushed down, the fluid accumulation is more, just 1500 ml.
Okay, okay. Push down. Okay, let's more about fluids up. I would suggest that you don't say pushed up or pushed down because ascites as a dependent edema, right? It's a dependent edema. So in abdomen, when you're in a supine position, the fluid will collect all over the flank and in the lower abdomen part. You're getting it? It will be a H shape. You know that H shape?
Yes.
Yeah. So it will be collected in a downward position and in the flank. So it is not going to be in the upward region. If that is the cause, then if there is no upward fluid, then in what way the abdomen will get pushed down? You are getting the point?
Yes.
Your fluid is getting collected on either side or in a downward because it's a dependent, right? It's a dependent edema. It will not go upward. When you lie supine, it will go to the position where it get rest. That is a dependent edema. So always it will be on either side and in the downward hypogastric region. So there is nowhere that this fluid go to the epigastric region and it will push your umbilicus. So it less likely it will push down unless there is an hepatosplenomegaly. If there is any hepatosplenomegaly, then it can get pushed down. Any upper GA pathology or any upper GA mass, then it gets pushed down. Any lower GA pathology or any ovarian mass, ovarian tumor, that can cause the push up of your umbilicus. So per se, ascites cannot cause a push down umbilicus. So umbilicus is in midline, everted, inverted, or transverse slit. But just with that, push down and push down is less likely, I guess, for ascites. Unless there is an hepatosplenomegaly. If there is an hepatosplenomegaly, yeah, you can say that could be pushed down. So you have to substantiate why it is pushed down. Okay. Another thing is good. Okay. Hernial orifices are normal. So what does that signifies?
There is no fluid is present in.
It always assimilate when there's a severe edema, severe ascites, even your hernial orifice get full. So in that way, it helps you to know how much everything, whatever I'm telling, it tells to help in the quantification of fluid. Even before you do the USG bar examination by palpation with flanks are full, umbilicals are everted, hernial orifices are full, it does tell that's a massive amount of fluid collection. So it signifies the quantity of the fluid that is collected in the abdomen. So that's the significance of seeing this all the parameters what we are explaining right now. Okay?
Yes.
Good.
Palpation, no warmth, tenderness is seen. No palpable mass or organomegaly is present. Percussion, shifting dullness is present. Fluid thrill is absent. Auscultation, normal pulse sounds are heard. No renal or hepatic fluid or venous hump is present.
In case if you are feeling any tenderness, means what you will think, no? On examination, while palpating that baby is crying excessively. And same time, baby is
Infections,
having fever.
peritonitis.
Okay.
Very good, exactly.
It is
So
known
what
as
is that called?
Hmm?
What is the full name of the peritonitis? What we say it as? What is the terminology used for it? You say
told
peritonitis. It is known as what? It's just not as the name is given for it. So we are asking that name. Peritonitis is correct, but what is the full name?
That I'm not sure.
It is spontaneous bacterial peritonitis. This is the full name. Spontaneous means there is no underlying GI pathology to cause the peritonitis. That is the implication of the word spontaneous. So spontaneous bacterial, the bacterial that is present in your normal flora in your GI pad, that is the one that is causing this peritonitis. So spontaneous bacterial peritonitis. Why there is a spontaneous bacterial peritonitis in this case? What is the reason for the peritonitis here?
Any infections?
Yeah, infection is one thing because there's a dysregulation of the immune system and that is loss of all immunoglobulins. That is one predisposed to infection. Apart from it,
Fluid is present
what
all
is stored
over.
in the abdomen?
Huh?
What is getting stored in the abdomen here in this
Fluids.
case?
So fluid will be
Exactly.
spread in all places.
So fluid means what happens? It is a
Infections
culture
can be
medium.
spread. Yes.
Exactly, that's a culture medium for any organism to grow. So you are giving a good culture medium. As it is become a good culture medium for the organism, even a normal organism that is present in your GI flora may infect the child. Even there is no other infection. So that is the reason these childs are very prone for bacterial peritonitis. That's the name. That's why we are naming it as spontaneous bacterial peritonitis because there is no GA pathology that predisposes to infection, and there is an ascites which become a medium where even a normal flora or any infection can cause a severe peritonitis. Right? So that's why we see a tenderness here. Okay, so how do you palpate organs, spleen and liver in the case of a severe edematous child? What is the method you use to palpate spleen and liver in this case?
Dipping method is used in this
Exactly,
case.
dipping. You use dipping method to see liver and spleen. So whether this liver is palpable in nephrotic syndrome, what are the conditions where the liver get become palpable?
In hepatomegaly,
Yeah, hepatomegaly. That's the question I'm asking. So what are the causes of hepatomegaly in nephrotic?
if the fluid accumulation is less, then it can be palpated.
No,
During inspiration, it is palpated.
that is push down liver. Okay, you are talking. I'm not talking about a push down liver. I'm specifically asking what are the causes of hepatomegaly in nephrotic syndrome?
Increased productions of proteins
Very good. What protein?
and
What protein? You're correct.
immunoglobulin,
What protein?
immunoglobulins, antithrombin,
No.
transferins.
Immunoglobulins are not produced by your. It's not produced by your liver. It's produced by lymph nodes, by B cells. B cells are not present in your liver. Your lipoproteins your VLDL,
proteins.
LDL, they are produced in more amount in response to hypoalbuminemia. So since there is more generation of all this lipoprotein, that's an hyperplasia of your liver cells. Okay, that's an hyperplasia of liver cell in order to produce more and more LDL and VLDL in response to low albumin. As a result, the patient may have an hepatomegaly. And second thing, if the child is having hepatitis hepatitis B and C, in early stage, in acute hepatitis phase, there may be an hepatomegaly. Right? So they are the causes of hepatomegaly in nephrotics. Okay. So what is shifting dullness and what is fluid?
Shifting dullness is seen if the fluid accumulation is from 1000 to 1500 ml. If in fluid thrill, the fluid accumulation is 2000 ml, then it will be seen.
Okay. Now tell me, fluid thrill is how do you perform fluid thrill? Just tell me the procedure, how to perform fluid thrill.
We must set the patient to keep his one hand in the middle of the midline, and then we should perform a tapping on one side. We want to feel it in the other side of our hand.
So what is the impression? What you will find by tapping?
Fluid movement is seen.
I'm asking on when you do this tapping on one side, in the other side, what you will feel?
Fluid vibrations.
Fluid vibration you will feel. So what is the importance of keeping a hand on midline of the patient abdomen? Why? What is the reason?
To maintain the rectus muscles stable.
Okay, one thing is there, another. What will be the other reason? Mainly your fat, your abdominal fat can conduct sound. So in order to prevent or in order to damp that sound conduction from your fat, we are keeping it in the midline. It's not because we have to keep the rectus in straight, it's to dampen the sound conducted by your fat, abdominal fat. This abdominal fat can also conduct that sound. So it gives a false impression that the child is having fluid. So only when you damp the sound that's conducted by your abdomen fat, you can see whether actually the fluid is the reason for that the thrill, what you see in that opposite hand on feeling it. And that is not percussion. Fluid thrill is a finding seen on palpation. Fluid thrill is not a finding of percussion. It's a palpation. You are palpating. You are not percussive. Percussion is this, right? This is the percussion.
Yes.
You are not doing that here, right? You are just feeling it, but doing this. So this is not a percussion. It's a finding of palpation. So always write fluid thrill in palpation, not in percussion.
Yes.
So if a patient is having fluid thrill, suppose your patient is having fluid thrill. Now, whether the child will have shifting dullness or not?
No, sir.
Why?
Because the fluid will be present all full abdomen.
Good. Yeah, exactly. That's the reason. So this is the question your examiner will ask. So any child who's having a fluid thrill never performs shifting dullness. Even you can say confidently, since the entire abdomen is filled with the fluid, I am unable to perform shifting dullness. So this is the simplest answer you should give in the exam, but you should know how to perform the step. But in a case a child is having fluid thrill, the child will not have shifting dullness. Shifting dullness will be absent in a fluid thrill. So this is the reason why all the entire abdomen get surrounded by the fluid. Let's see if the fluid thrill is absent, but you're not even getting the shifting dullness. So what could be the cause in that scenario?
Less than 500 ml of fluid is present.
No, yeah, one thing is good. You are saying that the fluid is more than 500 ml. Okay, you are having a fluid thrill of more. You are having around 1000 liter, one liter. It's around one liter of 1000 ml. fluid trill is absent, but shifting dullness is also absent. So what does that implies?
Fluid is present.
Yeah,
over
fluid
the
is
abdomen.
I'm giving a scenario where your fluid is 1000 ml. So there will be no fluid trill because that must be at least 2 liters. But the child is not having shifting dullness also. So what does that implies? So what we are missing here? We are missing if the fluid is loculated or cystic. If it is loculated or cystic, it will remain in that position only. So if you turn the child, this will not move. The fluid is 1 liter. You are seeing, you are doing a USG and they are saying it's around 1 liter, but it is not moving to that side. So most likely it is a cystic mass or it's a loculated cyst. So that is loculated ascites. That will not give a shifting dullness. Okay, so this you should keep in mind. When you are seeing a child having moderate ascites, fluid trill is absent, and also the shifting dullness. So what could be etiology? This could be the reason. That will be a loculated. Okay. Okay.
Yes.
Then auscultation, everything is normal. Then
Examination of other system, respiratory system, bilateral air entry, normal vesicular breath sound is heard, no added sound. Cardiovascular system, S1, S2 sound are heard, no murmur is seen. Central nervous system, no focal neurological deficit is present.
So here in central nervous system, in case this same child is presenting with seizures, what are the reason in nephrotic syndrome
very good.
for causes of seizure in nephrotic syndrome?
Because of formation of thrombosis,
Very
Very
good.
good. Then
peripheral thrombosis.
what? One thing you
Cerebral
said thrombosis. Oh yeah, very good. CSVT, central sinus venous thrombosis. That is the most common cause of seizure. Another thing, any other thing?
Hepatic encephalopathy.
What?
Hepatic encephalopathy is very unlikely. Na? We are talking about renal pathology.
Yes.
Yeah, you said one thing, you thrombosis. Okay, nice. Any other things?
Encephalopathy is okay, but it's not hepatic. Hypertensive encephalopathy.
Exactly. If it's a nephritic syndrome, or if the child is having nephrotic syndrome with significant lesion, not MCNS. If it's not a minimal change nephrotic syndrome, apart from that, the child is having some significant lesion like your mesangial proliferative or focal sclerosing glomulosclerosis type of lesion where that's hypertension present, then the child may go for seizure. That's another encephalopathy, hypertensive encephalopathy.
So
Any
already
other?
told about one sepsis, na? Like spontaneous bacterial peritonitis. Like that, any other infection can cause seizures?
They are more prone for what infection? We already discussed. The same thing can happen here also.
Is it encapsulated organism that leads to some
Pneumococcal
kind of
infections.
what kind of infection?
Pneumococcal infections.
Meningitis.
Gram-negative.
Meningitis.
Meningitis.
The child may have meningitis. And sometimes if you give fluid to this child, if you are not giving a proper fluid, they will have electrolyte imbalance, right? Because of electrolyte imbalance also, the child may throw seizure. Okay,
So
that's also.
dilutional hyponatremia. Okay, if you are adding diuretics, again that lead to more potent cause of hyponatremia. Got it? And one more reason, we are losing some amount of protein, globulins, some proteins, na, kind of vitamin D binding globulins. Okay, that leads to hypocalcemia. That also one of the cause of seizures.
Yes.
Okay.
So So
Yes.
these are the things for seizure. So tell me, what are the reason for thrombosis in a nephrotic in any child who are present in this kind of cases in a nephrotic syndrome? What are the causes of thrombosis? Why the child have a risk for developing thrombosis?
Because liver will secrete more
Yeah,
thrombin and more antithrombin is excreted.
Yeah. What are the things are excreted, not are produced?
More
You said
antithrombin is excreted,
antithrombin
protein
is
C and
uh,
S are
very
excreted,
good. Exactly.
and
So
increasing
what
production of fibrinogen.
good. Yes. That's
And
fibro is a important factor.
increase
Yeah,
of
factor five.
factors 5 and 8 and von Willebrand factors is
Good.
increased production.
Exactly.
This leads to hypercoagulability
Very good.
and formation of thrombosis.
So, exactly. Along with this dehydration, what the child is having already dehydration, they all predisposes to condition that's so now you see the child is having nephrotic syndrome, and you say that nephrotic syndrome there will be no hematuria, right? There will be no hematuria. Now this child is a diagnosed case of nephrotic syndrome is coming to you, but the child is presenting with sudden onset of hematuria, gross hematuria with flank pain. So this is a case of nephrotic syndrome. This is a classical case of nephrotic. It's already diagnosed. It's on all the therapy, but suddenly is coming to your emergency and with a flank gross hematuria, and also he is having a flank mass. So what would you suspect, and how do you treat this case? Are you getting the question?
Yes, sir. This is atypical nephrotic syndrome.
No. This is already diagnosed classical case of nephrotic syndrome. Frank hematuria, abdominal mass is there.
So what would you suspect, and how do you treat this case?
You already said about causes of seizure, na? Or central venous sinus thrombosis.
Yes,
So here what
Thrombus will occur at one place only, or it can occur multiple places.
it can occur in multiple places.
Yeah.
So
So what is here? Do you know renal venous thrombosis? It is RVT. So the child is having RVT. Renal venous thrombosis will present in this way. They will have a frank hematuria, flank mass, and when you do a blood picture, you will see a thrombocytopenia. So this is a classical triad of renal venous thrombosis, which is also most commonly seen in your nephrotic syndrome. So you should suspect. So you cannot go and he may be having a nephritic syndrome or significant lesion. Always rule out RVT in this case. Always rule out RVT. If RVT is absent, then you can go and see, okay, it may be a cause of any atypical nephrotic syndrome or nephrotic syndrome with significant lesion. But rule out RVT. After that, only you go to see what could be the other cause. Maybe a nephrotic syndrome or nephrotic syndrome with significant lesion. Right?
Yes, sir.
Then. Okay, then.
Diagnosis nephrotic syndrome, most probably minimal change nephrotic syndrome without any complications.
Without any complication. Okay. So this is a case of nephrotic syndrome. So nephrotic syndrome is where you should always mention when it's a first episode, right? It's the first episode. So you should respond because nephrotic syndrome recurs. That's a recurrent rate is high in nephrotic syndrome. It's relapse mode. So always mention the episode. It is a first episode nephrotic syndrome, right? You should always mention the episode also. So it's the first episode, right? There was no before the child doesn't have any episode before.
Yes, sir.
So it's the first
okay,
episode. Always
but let's assume I am the mother. Okay, so I admitted my child under you. You diagnosed nephrotic syndrome. Okay, first time. How will you counseling to that mother like me, the mother in front of you? Just counsel me. So I'm having some doubts. I don't know about this condition. So எப்படி counseling பண்ணுவீங்க?
Yeah, you should counsel in your vernacular language. So, since you are Tamil from Tamil Nadu, so you have to counsel the patient party in their own language, the simplest language they learn, they can replicate in their own. That is the most important. Whatever you treat, it's not that important because nephrotic syndrome will have a relapse. If they don't do the proper monitoring, the child will have relapse, and they should know when to take the child back to you. So that we should do a proper counseling after the treatment. So what would you say?
I would say the child is having nephrotic syndrome. We'll give some steroids, which is of prednisolone, which is given 20 mg per day, which is you want to continue it for 6 weeks. Then after 6 weeks, it was be decreased
You
to
tell in Tamil. You should know how to communication is very important. So you tell me in Tamil. Just explain this in Tamil. So sir is he's the mother of the child. So you tell in Tamil. Explain the same thing in Tamil.
குழந்தைக்கு வந்து நெஃப்ரோட்டிக் சிண்ட்ரோம் அப்படின்ற ஒரு டிஸார்டர் இருக்கு. ஸோ அதுக்கு வந்து நாங்கள் பெர்னிசோலோன் அப்படின்ற ஒரு டேப்லெட் தருவோம். ஸோ அந்த டேப்லெட்டை வந்து நீங்கள் 20 mg பர் டே அந்த மாதிரி போடணும். அது ஒரு 6 வாரத்துக்கு நீங்கள் போட்டே வரணும். அதுக்கப்புறமா உங்களுக்கு வந்து 3 நாளைக்கு அது வந்து கம்மியாயிடுச்சு அந்த சிம்டம்ஸ் தான் இப்போ இருக்க சிம்டம்ஸ்னால் அதுக்கப்புறம் நீங்கள் அதை 4 வாரத்துக்கு வந்து நீங்கள் அப்படியே கண்டினியூஸாக போடணும். போட்டுக்கு அப்புறமா டெஸ்ட் பண்ணி பார்க்கும்போது 3 வாட்டி டெஸ்ட் பண்ணும்போது அது கம்மியாயிடுச்சு இல்லைன்னா நீங்கள் நிறுத்திடலாம். ஸோ அதுக்கப்புறம் உங்களுக்கு வந்து கொஞ்ச நாள் கழிச்சு மறுபடியும் இதே மாதிரி உங்களுக்கு ஸ்வெல்லிங் ஆகுறது ஃபேஸ் தான் இந்த மாதிரி ஆகிறது இருந்துச்சுன்னா மறுபடியும் நீங்கள் வந்து ஹாஸ்பிட்டலுக்கு வந்து பார்க்கணும். ஸோ அப்போ வந்து மறுபடியும்
இது
நாங்கள்
வர்றதுக்கு
ட்ரீட்மெண்ட் தரோம்.
சான்சஸ் எவ்வளோ சான்சஸ் இருக்கு? லைக் what are the possibility of recurrence if I'm asking from other side?
இப்போ அந்த டேப்லெட் ஸ்டீராய்டு டிபெண்ட்டாக இருந்துச்சுன்னா உங்களுக்கு அந்த டேப்லெட் போட்டால் கம்மியாயிடும். இப்போ அது ஸ்டீராய்டு ரெசிஸ்டண்ட்டாக இருந்துச்சுன்னா உங்களுக்கு அந்த டேப்லெட் போட்டால் கம்மியாகாது. ஸோ
Steroid
ரீனல்
sensitive.
பயாப்சி அந்த மாதிரிலாம் எடுக்கணும்.
இது ஸ்டீராய்டு சென்சிட்டிவா வச்சுக்கோங்க. ஸ்டீராய்டு சென்சிட்டிவ்ல எவ்வளவு % ரெக்கரன்ஸ் ஆக வாய்ப்பு இருக்கு? They are sensitive. ஆனா ரெக்கரன்ஸ் வரும். ஃபர்ஸ்ட் 6 மந்த்லயே எவ்வளவு % ஆஃப் சில்ட்ரன்ஸ் வந்து ரெக்கரன்ஸ் ஆகும்?
So the counseling is very important. First, you need to introduce by yourself. I'm the doctor. I'm your child doctor. So I know your child condition. We came through a lot of investigations and examination and history wise. We diagnosed this is the condition. So before revealing that condition to that mother, you should know the mother's knowledge about that condition. Whether some mothers may be educated, some others may not be educated. So just ask them whether they know any idea about nephrotic syndrome. Let them assume their knowledge. After that, you can slowly counsel them according to their level of knowledge. Okay. Then slowly say nephrotic syndrome. This is the first episode. Most of the time they will respond 80%. They will achieve remission. Still 10 to 20% relapse can happen. So we need to wait and watch. During therapy, some complications can develop. We need to monitor those complications frequent intervals. So you need to explain those things. Apart from prednisolone, any other medication you want to provide, that also you need to advise. What are the things the mother should monitor at home level, like urine dipstick, everything you should demonstrate at bedside and then discharge the child. So one more question I want to ask you. This is first episode. You want to admit this child or you want to treat the child OP basis? OPD basis.
I want to admit and
Why? Because the child is like clinically stable. You diagnosed nephrotic syndrome. You want to do some investigations. What you want to do with the child in hospital?
I should know about the
Hmm.
steroid is decreasing the facial puffiness or not.
So that takes some time, no? So still that time you want to keep the child in what? So like simple nephrotic syndrome, unless otherwise there were no other complications, you can treat the child on OPD basis. Admissions for indication like they are having hypertensive urgency, hypertensive emergency, significant anasarca or generalized edema, and complicated like steroid complications and frequent relapse. These are all the indications you need to admit the child. They having hypotension and AKI. Okay.
Yes.
I would also add some points here. As sir said, whatever the counseling, you should counsel in that way, in their own language. You have to detailedly explain it. You should know KAP practice. What is KAP? KAP. You have read it in your community medicine. What is KAP?
Knowledge, attitude, practice.
Yeah, exactly. That is the sir was asking you, was telling you. You should assess the knowledge of the parents, whether they know about the disease, even after explaining whether they're aware of that or not. One thing. Second, attitude. What is the attitude? Whether they are maintaining. For example, the child is having second episode. So first, after having his first episode, whether they are neglected or not, because most of the childs are very neglected. They will take the child only after severe edema is developed. There are few parents who are very careful that even a periorbital puffiness appears, they will take the child to you immediately to you. There are few parents who will wait till the generalized edema and that is when anasarca develops. So you should know the attitude, how they respond to the disease. This is the attitude. And practice the steroid diary, how they are maintaining the steroid diary, how do they maintain the urine diary, where they are proper, they are very consistent with that. So these are the practice and how they are following the child. So this is the KAP. This is the knowledge, attitude, and practice toward that particular disease. So you should assess this. That is the one thing. And second thing, as sir told, what okay. So you should also explain the steroid diary maintenance and urine dipstick. This should be maintained in a diary, and you should tell them how to. And another thing, how to write it, because there are illiterate parents, right? So illiterate parents, how do you tell? எப்படி நீங்க சொல்றீங்க இல்லிட்ரேட் அவங்க படிக்க கிராமத்துல இருந்து வராங்க, கிராமத்துல இருந்து வந்து உங்ககிட்ட வராங்க, அவங்க கிட்ட நீங்க என்ன மாதிரி எக்ஸ்பிளைன் பண்ணுங்க, அவங்க எழுத படிக்க தெரியாது, சோ அவங்களால டைரி மெயின்டைன் பண்ண முடியும். அப்ப என்ன சொல்லுங்க? அவங்க யூரின் லிப்ஸ்டிக் அவங்களால பார்க்க முடியல வச்சுக்கோங்களேன். அப்ப என்ன சொல்லி அவங்க இந்த மாதிரி வந்துச்சுன்னா நீங்க வந்து உடனே எங்க கிட்ட வாங்க, நாங்க பாத்துக்கிறோம் சொல்லுங்க. Because these are the reality you will face in the day-to-day practices. Whatever we are reading in book, it's not going to apply everywhere. If you're going to a rural area, அங்க எல்லா டெஸ்டும் இருக்காது. அப்ப நீங்க வந்து அவங்கள வச்சு நீங்க சொல்லவும் முடியாது, நீங்க இதெல்லாம் பண்ணிட்டு வரணும். அவன்கிட்ட காசு இல்லைன்னா அவனால யூரின் டெஸ்ட் வாங்க முடியாது. அப்ப என்ன சொல்லுவீங்க? இதை வச்சு அவங்க கொண்டு வருவாங்க. அட்லீஸ்ட் அந்த நாலேஜ் அவங்களுக்கு கொண்டு வரணும். அவங்களுக்கு சொல்லணும், சிம்பிளா சொல்லணும். அப்ப என்ன சொல்லுவீங்க?
ஃபேஷியல் பஃப்னஸ்லாம் வந்துச்சுன்னா வரணும் அப்படின்னு சொல்லுவாங்க.
மூஞ்சி வீங்க ஆரம்பிச்சிச்சுன்னா அப்ப வந்து உங்களுக்கு பையனுக்கு ஆகுது. அப்ப நீங்க வந்து பக்கத்துல ஆரம்ப நிலையம் அங்க போய் பாருங்க, இல்லைன்னா பக்கத்துல ஏதாவது டிஸ்ட்ரிக்ட் ஹாஸ்பிட்டல் அங்க அது வெரி குட். அது ஒண்ணு. இன்னொன்னு ரொம்ப காமனா யூரின். நீங்க யூரினை வச்சு எப்படி சொல்றீங்க? யூரின் எப்படி இருந்துச்சுன்னா உனக்கு வந்து பிரச்சனை திரும்பி ஆரம்பிச்சு, அப்போ உடனே நீங்க வந்து எங்க கிட்ட வாங்க, இல்லைன்னா பக்கத்துல ஏதாவது டிஸ்ட்ரிக்ட் ஹாஸ்பிட்டல் போய்
டிக்ரீஸ்டு ஃப்ரீக்வன்சி டிக்ரீஸ் ஆயிடுச்சுன்னா
ஓகே. ஃப்ரீக்வன்சி அது வந்து டிலேட் இல்ல. ஃபர்ஸ்ட் எடிமா டெவலப் ஆயிட்டுன்னா ஆடிக்குரியா வரும். அப்ப நீ டிலேட் ஆயிடுச்சு இல்ல. அப்ப நீங்க வந்து
யூரின் பிரசன்ட்
இதுதான் நீங்க சொல்லணும். இந்த ஃப்ராத் யூரின் இருக்கா இல்லையான்னு நீங்க பாக்கணும். ஃப்ராட் யூரின் இருக்கு, இந்த மாதிரி ரொம்ப நுரையா வருது, நிறைய நுரையா இருக்கு. முன்னாடி நார்மலா நுரை இருந்துச்சு, இப்ப ரொம்ப அதிகமா நுரை வர ஆரம்பிச்சுன்னா அப்ப வந்து பிரச்சனை திரும்பி ஆரம்பிச்சு, அப்ப உடனே இங்க குடிக்கணும். சோ இந்த மாதிரி நீங்க எக்ஸ்பிளைன் பண்ணும். இல்லிட்ரேட் ஃபேமிலி அவங்களால எழுத படிக்க தெரியாது, அவங்களால அதை மெயின்டைன் பண்ண முடியாதுன்னா அவங்க கிட்ட நீங்க இந்த மாதிரி கண்ணு வீங்க ஆரம்பிச்சிச்சு, இல்லைன்னா அவங்க யூரின் வந்து ரொம்ப ஃப்ராட்டியா இருக்கு, இந்த மாதிரி ஏதாவது வந்துச்சுன்னா உடனே வந்து கூட்டிட்டு வாங்க அப்படின்னு நீங்க சொல்லணும். So this is the way you have to explain the parents. This is the very important. Nephrotic syndrome is something which is relaxed. It's very common. I am Tamil Nadu, West Bengal. I am doing my practice in West Bengal. So இங்கேயும் ரொம்ப common. But the point is the counseling part is not done very well. So always they are neglected. They are taken during the time when the child is completely generalized in assault.
Okay.
So this
how will you evaluate this child, no? Can you say about further?
What is the way? How do you evaluate the child? So this is the first case of nephrotic syndrome. It's the first episode. So how do you evaluate the first episode of nephrotic?
Investigations.
Yes, yeah.
Yeah, what are the
Investigations.
investigations will do? Exactly. What are the investigations?
Complete blood count. Urine analysis.
Before that, complete blood count is not an investigation of for a nephrotic syndrome. Always nephrotic syndrome is a clinical diagnosis. First thing you should do. But making a diagnosis, what are the criteria you should fulfill? What are the criteria to say that a child is having nephrotic syndrome?
Protein profile will be taken. So
What
we
protein
can
profile
able
will
to
be
find to check the albumin level.
exact. So serum albumin you are seeing. Then
Serum albumin. And
then
lipid profile level is checked.
okay. So tell me, the lipid profile is essential for diagnosis right now? According to the
Yes.
recent definition, whether lipid profile is required for the diagnosis of nephrotic syndrome or not.
Yes.
Now they
No.
remove. Okay, so only 3 criteria.
They have removed it. So you don't need the lipid profile for the diagnosis of nephrotic syndrome.
3
Okay, so
criteria. One is edema, second one is high proteinuria, third is
Hypoalbuminemia.
edema
yes.
or serum albumin. Why they? Because lipid profile, if you see the lipid profile, really பார்த்தீங்கன்னா எல்லா institution when you go to outside campus, outside area, lipid profile is not going to available in all center. And another thing is that it's very non-specific for nephrotic syndrome. In any case, there is an hypoalbuminemia. Any case of hypoalbuminemia, you will have TGL raise. So that's
So
not going
whenever
to
you,
be only for nephrotic syndrome. So if
so
for
if you want to
nephrotic
start
syndrome,
with the investigation, so go with urine in nephrotic syndrome. Urine is the first line investigation. What you will look for in urine?
Protein is present or
Yes, one is
RBC
urine
cells are
dipstick,
present.
either 3 plus or 4 plus. Good. Next,
Yes.
24 hours
RBC
urine protein
cells
is
present.
ideal, but sometimes it's not possible. So we want to monitor that urine protein, whether it's range in nephrotic range or not. Okay, good. Next.
RBC is present.
Yeah, that is okay. So whether it's microscopic hematuria or macroscopic hematuria, whether it's there or not. Okay, then urine culture is required.
Yes, sir. To rule out any UTI infection.
Only if simple nephrotic syndrome, minimal change disease, no other complications, no other urinary symptoms, no need to do urine culture. Okay. Okay. So
Yes.
second line. Okay. First you completed urine. Next.
Serum protein and serum lipid level.
Okay. Okay. So
Renal
you
function
can say
test.
total protein and albumin. Okay. And cholesterol levels also. So
Yes.
complete blood count. Yeah, the two part of investigation. Okay. To know whether
Yes.
that dilution hematocrit also. Okay.
Yes.
and very most importantly, what is the thing you should do? These are the things which for diagnosis. But what you should do, you should not miss it here.
Renal function test.
No, renal function test is not needed as a primary. It's a secondary investigation. Primary investigation, all whatever sir said and you told, that is a primary investigation. If any complication is arising, then only if you are suspecting some other thing, then go for the secondary investigation, which we'll discuss in some while. But what is the most important thing you should do? That is for your treatment purpose. That is for your treatment purpose. So what you will do?
Any infection test is for tuberculosis.
What
we should
infection
do.
which is very
Tuberculin test.
Yes.
What? Tuberculosis.
Yes.
Very
Your
good. Okay.
tuberculosis.
So already I think you committed while discussing about BCG. Tuberculin test is for latent tuberculosis. Whenever tuberculin test is positive, next you need to do chest X-ray. Chest X-ray is suggestive of any latent tuberculosis. You need to go with isoniazid for 6 months.
Yes.
Okay.
Good. So any other additional evaluation, additional investigations? Always you need to rule out whether the child in hypovolemic state or not, or pre-renal AK. Okay, especially like this child, you are not able to commit reduced urine output, whether that volume is low or some Other reason we don't know. So better to one urea creatinine.
Yes.
And same time electrolytes. We need to start Lasix if required. So baseline electrolytes we should know. Okay. Okay, so
So,
other investigations are like if you are suspecting secondary causes of nephrotic syndrome means you need to do ASO titers, complements levels, and some IgA vasculitis. All the things are according to that etiology and clinical history suggestive of. Okay, okay.
Yes.
okay, right now your case was a first episode of nephrotic syndrome, and you diagnosed, you did a urine dipstick which came as 4 plus, and serum albumin is 2.2 mg, gram per deciliter, and the child is having a generalized edema. So it is a case of a nephrotic syndrome, and it's a first episode, a 2-year-old child, and his tuberculosis test is negative, and all other secondary causes have been ruled out. Now, how will you treat this case?
For management, protein
Yeah.
intake must be given.
Yeah, what?
Dietary protein intake must be given.
Okay, before we give me diet evidence, that is a supportive management. What is the main treatment for the child? So how do you treat the child? The first episode of
Steroids,
exactly.
prednisolone is
What
given.
steroid will
Prednisolone.
prednisolone, oral or IV?
Oral.
Oral, exactly. That's the one. Oral prednisolone. There is no role of any IV medication. The treatment drug of choice is prednisolone, oral prednisolone. So what is the dose for first episode of nephrotic syndrome? What is the dose of prednisolone?
2 mg per kg per day.
Day.
Okay.
2 mg per kg per day for how long?
6 weeks.
For 6 weeks,
So
it
like
divided
that
dose or single
nephrotic
dose?
syndrome, yeah, Prithvi. Here, instead of telling per kg, always commit with body surface area because nephrotic syndrome, na, weight is not accurate. So you should know about body surface area dose calculation. 60 mg per meter square body surface area is the ideal recommendation. In another way, we are telling 2 mg per kg. Okay. In alternate days, like after completion of 6 weeks, alternate days regimen, again 40 mg per meter square body surface area or else 1.5 mg per kg. But kg is for rough estimation, ideal dose according to that body surface area.
Yeah. So you should know the both the value. For remember sake, you go with 2 mg per kg per day. If anyone asks what other criteria you say that meter
Yeah.
square, 60 mg
In
per meter
exam
square.
purpose, they may ask this question. Yes.
They may ask you, but you should know both the thing. For rough calculation and for easy remembrance, you go with 2 mg per kg per day in 2 divided doses. We don't give a single dose. We give a 2 divided doses, and that has to be given every day for 6 weeks, followed by what? Followed by after 6 weeks, what you will do?
After 6 weeks, we should give alternate doses
Alternate dose of what?
prednisolone.
Yeah.
How much dose?
How much dose?
Just 1.5 mg or 40 mg
Per
per
meter square. Very good.
meter square of body
Okay.
surface area.
For how long? Time duration?
For 6 weeks.
Exactly. After 6 weeks, what you will do?
Any remission must be seen. 3 consecutive tests will be done to
Okay.
see any remission.
So, what is the definition of remission? And what is the definition of relapse? Tell me. So we will wind up.
Remission.
So time is. Yeah. What you tell?
The disorder was cured, that is remission. Relapse, the disease is reoccurred after some time, just relapse.
So what you are saying, remission is because the disease is cleared of the treatment and relapsing disease reoccurred. But that is your subjective definition. What is the objective? How do you tell that the child is having a remission? How do you tell that the child has gone into remission, and how do you tell the child has again had relapse? In what way you will confirm?
By
What
urine.
Yeah, urine. What
dipstick
is the
test.
urine? Exactly.
3
What you will see.
consecutive tests must be seen.
Done. What sample is taken for your urine dipstick here.
All words are important. Okay. So remission, this is urine dipstick, what you said, correct. Whether that nil or trace of 3 consecutive days of early morning sample. Got it?
Yes.
What about relapse?
After sometimes the disease must be reoccurred, just of swelling or puffiness
Okay,
over the
how do you
face.
define definition? It's just an subjective. What you say is correct, but how do you confirm it?
Massive proteinuria, frothy.
Yeah,
How do
massive
you define the
proteinuria means how much?
How do you define it?
Already we said, na, nephrotic range of proteinuria, urine dipstick
Greater
more than
than
3 plus. Yes,
3
greater than
plus.
3 plus in 3 consecutive early morning specimen. The child should have been in remission previously. Okay.
Exactly. This is very important. So,
Yes, sir.
So, in both the cases, we told that 3 consecutive sample of early morning sample has to be taken. What is the reason behind telling that we should take early morning sample, not the afternoon sample or night sample? Why? Why it is very specifically told in every book, early morning sample. What is the implication of early morning sample? Not your day, night, or afternoon sample.
In early morning sample, more
Why
proteinuria we see.
I'm asking what is the implication of that? Why not afternoon or night sample? Only why early morning sample?
In afternoon sample, protein will be not seen more.
What again? Tell it again. You repeat it.
In after
In
sample, protein will be not seen correctly.
In what way?
Level.
Protein will not be seen correctly.
Shifting
Just
of
define it.
fluids.
What you want to say. What protein is not seen correctly means it's increased or decreased.
Increased protein will not be seen after morning.
After morning, the protein level in urine decreases or increases.
Decreases.
No, see, that's a concept called as orthostatic proteinuria. Orthostatic proteinuria means once the child or any person, whatever be the, even a normal person, after he wakes up, he passes the urine. At that time, he has some protein. Once he start to work, okay, when he start to do his day-to-day routine activities, what happens? There are a few mechanisms because of hyperlordosis, there are the renal vein compressions, like that. There are a few mechanisms by which what happened? The protein started to be lost more in the afternoon night because of the day-to-day activity they perform and some biomechanical factors, it increases the protein secretion in the urine, which given false positive urine, and we misdiagnose a nephrotic syndrome. That is not because of nephrotic syndrome. It's because of some biomechanical, obesity or hyperlordosis or renal vein compression. These are the few factors that happens as the person do day-to-day activities as he goes day, night. So that will be proteinuria, which is because of other cause not related to the nephrotic syndrome per se. So this give a false positive. In order to reduce that false positivity and over-treating these patients who actually don't have any nephrotic syndrome in first place, we do a early morning sample because early morning sample give an exact thing without any all these factors are negotiated. Whatever I said, the biomechanical factor, obesity, hyperlordosis are eliminated early morning sample. in that way, that's the reason why all guidelines suggest to do an early morning sample, not the night sample or afternoon sample. Okay.
So one last question
Yes.
from my side. I need to leave by shortly. So what are the adverse effects of long-term steroids?
Yeah.
Steroid toxicity will be seen.
Yeah. What are the
Infections can be
toxicity?
occur.
What you
Yeah,
will
yeah.
see?
What are the toxicity features?
So,
What are the steroid toxicity features you will see or you should see in any patient who was on long-term steroid?
if a child has fever, the fever will be not seen when using the steroids. Suppression of
Okay,
the
that is
fever
no
is
suppression.
seen.
Okay, that's one thing. Another thing, you will see hypertension. Yeah, you go with that. Obesity, growth retardation, Cushingoid picture, Cushingoid syndrome. You will see cataract, you see glaucoma, you see osteonecrosis,
Sometimes,
osteomyositis,
yes.
psychosis. They are
These are
all the
all are side effects of steroids. So you need to monitor the child very carefully, like anthropometry once in every 3 months, blood pressures and blood sugars also, whenever you are asking the child for visit, especially transaminases and blood sugar, 3 months to 6 months once. And you need to examine the child eye for intraocular pressure and cataract 6 months once. Okay. So apart from steroids, you need to supplement any other drugs for this child?
Yes, sir, if steroid is not possible, levodopa,
No, those are all
cyclophosphamide.
second line drugs.
We are just talking about the first episode of nephrotic syndrome. We didn't go for
Syndrome.
frequent class or steroid resistance. We are just talking about first episode. Our class is only on first episode. We are not going to do it because that is elaborative topic. We need another class to discuss on it. We don't go for that steroid sparing drug. The child is not having that steroid toxicity. He's all normal. He's responding to the steroid. But sir is asking what are the other drug you will prescribe apart from steroid in this case.
So we already discussed, no?
Diuretics.
Diuretics. Okay, fine. Okay.
Okay, good diuretics. Then
So we told, na, like hypocalcemia common in nephrotic syndrome because of child is losing vitamin D binding globulins as well as steroid induced osteoporosis. Though that's why the child should receive vitamin D as well as calcium supplementation. Okay.
exactly. So you should give that.
Whether the
So
child require a thyroxine, because thyroid binding globulin also child is losing in child urine, no? So the child
Yes,
is
yeah.
requiring thyroxine?
yes, sir.
No,
There,
actually that so thyroxine not required. If once you start the prednisolone, this obviously will get automatically corrected. This is called biochemical hypothyroidism. Clinically, those symptoms won't be there. Okay, no need to provide thyroxine. But vitamin D and calcium is mandatory.
okay. So final question from our side. So we'll wind up the session because it's more than 2 hours. So what is the dietary advice you will advise for this patient? For the first episode of nephrotic syndrome, what would you advise the mother? The mother is asking if you want to நிறைய sugar சொல்லணும் chips pickles அந்த மாதிரி கொடுக்கலாமா இல்ல எப்படி நான் கொடுக்கணும் so how would you advise the dietary advice for this patient?
Increase in protein intake must play.
So how much
Okay.
protein intake you will tell? Tell me how much protein the child may take.
1 gram per kg.
1
That is
gram per
the
kg
ideal,
per day.
that is very normal recommendation. The
For
child
this
required almost 1.5 to 2 gram per kg per day.
so you should give 1.5 to 2 gram per kg per day. Okay, that is the ideal for this because already the child is losing all the albumin and protein. In order to compensate that, so the body requires more protein. So a recommended allowance with the recommended allowance, you should also substitute more so that you can compensate for the loss. So it goes with 1.5 to 2 gram per kg per day. This is one thing. So what about the sodium? What about the salt? Whether you will advise salt restriction for this child or not? If yes, why? If no, why?
The child must be given salt restriction, but the normal intake of salt in the food is must be given.
Exactly,
Extra, the
exactly.
chips, that is not to be allowed.
Good. This is the answer everyone requires because many people say that salt-free diet. There is no concept of salt-free diet. There is no concept of any salt-free diet because without salt, the food is not palatable. You cannot eat a food without salt. This is the reality. So in reality, if you see, this, without salt, no food can be palatable. So salt must be present in the amount which is present in the food. You don't add an extra salt, right? So salt restriction in the form of extra salt should be avoided, but normal salt which is prescribed for that food, which is present in a minimum value, that can be given. That is 1 to 2 milliequivalent per kg per day. This is the minimum salt requirement which can be prescribed to the child. So protein, salt, these are the things you will see, and you see balanced diet. Balanced diet, protein with calorie and protein requirement and salt restriction should be there, but excess salt should be avoided. Normal salt, which is required for that particular child, must be given. Right? So this is the final dietary recommendation, and this is the case which you discussed with us in the first episode of nephrotic syndrome, most probably a MCNS. As we discussed MCNS, what is the point favoring for this MCNS? Why you are saying it's an MCNS? Minimal change nephrotic syndrome. What are the points which will support your diagnosis? Just tell it and we will wind up the session.
In nephrotic syndrome, the most common 80% of disease is minimal change nephrotic syndrome.
Okay, then.
So start from age wise. Okay, this is 2 years old child,
Yes,
presented with generalized anasarca, no other complications like hematuria, rashes, nothing secondary nephrotic syndrome, signs and symptoms was not there, and your basic evaluation, urinary and blood test suggestive of nephrotic syndrome. Okay.
Yes.
So this is so that's the thing. You don't have any other features like hypertension, hematuria, or persistent edema, and responsive to steroid. It's very important. The child is responding to steroid and is after giving 1 to 2 weeks of steroid, the child started to improve a lot. His weight decreases, abdominal gut decreases, and he become easy appetite increases. So everything it goes in favor of MCNS. If it was a case of FSGS or messenger proliferative or membranous proliferative glomerulonephritis, then it will not respond to steroid. And you will also have other symptoms like hypertension, rashes, hematuria, and child condition deteriorates. So these are the points which favors the MCNS. So this is a case of first episode of nephrotic syndrome, most probably due to MCNS with no other complication. This is the way you have to end your case. So with this, we'll wind up. You did presented very well for your first
Very good
presentation.
presentation. Okay, you presented nicely. Way of discussion also very good. But you need to improve in development as well as nutrition part. Okay.
Yes, sir.
Yeah, developmental, you should write all the things. As I said, 6 components must be written. And second, nutrition, always follow the recommended chart of your ICMR and NIN. And what we say the weight-based criteria and also the anthropometry. Anthropometry, you wrote expected and the child actual weight, but you didn't plot it in the growth chart. You should not follow any weight-based formula. That is just for your theoretical knowledge and theoretical examination they will ask. But in reality and in your exam, you should plot the growth chart because growth chart will carry an important mark. If you don't plot growth chart, that will have a negative impact on your paper because they will reduce. They have the right to reduce the bar because growth chart is vital for pediatrics. Without growth chart, there is no examination will complete in pediatrics. So plot the growth chart. Okay, anthropometry must be written with the growth chart. give the inference with the Z value -1, -2, -3, +1, +2, +3, or centile, 3 centile, 5th centile, 25th centile, 50th centile, 75th centile, 96th centile, 97th centile. So in that, you have to give whether it is in which class they are coming, and that inference will tell you it's a normal for age or sex, or it is abnormal for age. So these are the things which you should take care in your next presentation. Apart from that, you did present well to add a good knowledge about it. Okay. So we'll
Okay,
wind up.
thank you. Thank you, Prithvi, for the good opportunity. Thank you.
Okay, sir. We'll wind up. Now I will give the mic for the conclusion remarks to Dr. Patil.
Thank you so much, Dr. Prithviraj and Dr. Karthikeyan sir. I also thank Madhumita for her elaborate presentation. And I think our subscribers found it very useful. And thank you for such an elaborate presentation once again. Hoping to meet you again, both of you, sir.
Okay.
Thank you. Thank you.
We'll conclude the session now. Thank you.
Sure.
Thank you, Madhumita. Thank you for joining.
Thank you.